And we'll now go to Rasha Kamel from Cairo, Egypt, who's going to present intrapartum ultrasound in the prediction of cesarean section in women having induction of labor. Rasha?
Thank you very much for the chance to be with you, for having me over. I would like to present our latest published study. It was recently published in the AJOG. It was about predicting the outcome of labor induction, a model development and validation. This was a collaborative study between Cairo University Hospitals, Bologna University Hospitals, and the Fetal Medicine Research Institute in London. So because induction of labor is one of the commonest interventions and its prevalence is expected to continue to rise, and because in nulliparous women especially, there's an additional challenge because there's a reported incidence of 15 to 20% failure ending in emergency operative deliveries, several clinical and ultrasonographic parameters have been evaluated as predictors to the outcome of induction of labor, but all of them produced varying results. So we conducted our study to try and identify and validate a reliable, reproducible model for prediction of the outcome of induction of labor in nulliparous women. Our study was a prospective observational cohort study. We included 382 nulliparous women undergoing induction of labor at term. They all had a baseline cervical clinical assessment using the modified Bishop score by the attending obstetrician. Then they had a transabdominal ultrasound examination for fetal biometry and occiput position identification, followed by a transperineal ultrasound examination for determination of cervical length, angle of progression, anteroposterior diameter of the elevator hiatus, head to perineum distance, head to symphysis distance, all at rest and at maximum Valsalva. The attending physicians were blinded to the ultrasound findings, and labor was managed according to the guidelines of our hospital. For the transabdominal examination to identify the occiput, the transabdominal probe was held at the umbilicus and then slid downwards to the suprapubic area, where we identified the presenting part and we located where the orbits were and where the occiput was. And in this way, we could identify the occiput presentation of the baby. For the transperineal examination, we held the curvilinear probe transperineally or translabially. We first assessed the head, the angle of progression, and as it was described by Boris, this was first published by Barbera et al. It's the angle between a midline longitudinal angle through the symphysis pubis, ending into the most inferior point of the symphysis pubis, and then another line dropping from that particular point tangentially to the fetal skull. And this would be the angle of progression, determining the fetal head station. And then we also determined the head to symphysis distance, which is a line from the most inferior point of the symphysis pubis along the infrapubic line to meet the fetal skull, and the cervical length, which is a line along the endocervical canal from the internal to the external os. Our results showed that we could perform all the required sonographic parameters successively on all the participants of the study. We focused on the variables that are objective and that are reproducible to try as much as we can to minimize the inter and intra-observer variability in order to establish a reliable model. Then we carried out our analyses. We did univariable and multivariable analyses for selection of the potential predictors and for the model fitting. These were the independent variables that were found to be significantly associated with the cesarean delivery. It was the age of the mother, the cervical length, the angle of progression at rest, the angle head to symphysis distance at Valsalva, and the occiput position. And we could formulate this equation for calculation of the individualized probability of cesarean section for each woman in labor, where we could just fill in the variables here: the age, cervical length, angle of progression at rest, head symphysis distance, Valsalva, and the occiput position. And of course, E here is the mathematical constant. And then in this case, we can actually try to calculate the probability of cesarean section for each woman. We tested the performance of our model by this ROC curve, and the area under the ROC curve was 0.77. Then we internally validated our model, and we performed another ROC curve, and the area under the curve for the cross-validated cohort was 0.88. we carried on with our trying to validate our results. We tried to include as well the patients who had cesarean delivery for fetal distress. Primarily, we were testing the women who had cesarean delivery for failure to progress, but then we also included the women who had cesarean delivery for fetal distress as well, because there's a possible overlap between cases that have cesarean section for fetal distress, possibly due to prolonged labor, due to failure of progressive labor as well. And the area under the curve for the model development was 0.73 in these cases, and for the validation cohort was 0.87 in these cases. So they were just a split. So in conclusion, we conclude that the maternal age, the sonographic assessments of the fetal occiput position, angle of progression at rest, cervical length prior to labor induction were all found to be good predictors of induction outcome in melliferous women at term. And if we can apply a model comprising these parameters, this might actually help obstetricians to identify the women at high risk for induction of labor failure, and of course, individualize the care offered to them, thus trying to improve the clinical outcomes and to optimize the cost effectiveness of the healthcare interventions. Of course, it would be prudent, and we do recommend to validate our model on other independent cohorts to further test its predictive performance. Thank you very much, and happy Valentine's to all. Thank you.
Thank you, Rasha. There were a couple of questions. Katia Bilardo wanted to ask a question earlier. Katia, are you there?
Yes, I'm here. So first of all, I enjoyed very much the presentations. I'm really convinced that ultrasound has a place in the labor world, and you managed to convince me today even more. Well, my question is for Ali. His presentation was very, very interesting. What I wonder is it possible to select already before delivery the women at risk of this malfunction of the pelvic floor? Well, you mentioned something about endometriosis, but I would have thought that maybe women with vaginismus would be more prone to this malfunction. Because I think that if we could combine all the measurements with this would be a very important step forward. Well, when would this happen? Before delivery, let's say during pregnancy, because we know that women during labor sometimes cannot really internalize what is told to them. So if they already in advance would be able to practice and to be aware of the right movements, I think it would be important.
Thank you so much, Katia, for the question. It's extremely relevant, and I do believe so, but I do not have data on that. Okay, so we know that women. I talked about endometriosis because we have collaborated on with our group of deep infiltrating endometriosis, and I would be careful on calling the coactivation a malfunction, okay? Because we know that it's quite common. About 25 to 30% of women do have it. We know that apart from delivery, most of them do not have any symptoms. Okay, so and we even with coactivation, most of women will not have a problem, but they are at high risk. So what I think that the next step is an RCT. Whether two RCTs actually, one before the onset of labor, so diagnosing the coactivation before the onset of labor, doing some session of physiotherapy and visual feedback, and this is the first study. The second RCT is a coaching, randomizing these women to ultrasound coaching versus no ultrasound coaching during the second stage of labor. But this is what I would believe that it may work, but I do not have data on that.
Sorry, may I just ask something?
Sorry, Katia, carry on.
Has it got a relationship with the episiotomy, the chance that you have to put an episiotomy?
Well, in our hospital, we have an extremely low rate of episiotomies. It's between 1 and 2%. Okay, and we did not find whether in our population or the population together with the Cairo University, we did not find a correlation with episiotomy, and we did not find a correlation between severe perineal tears. Okay, so but we did not examine the levator ani avulsion, which is another thing, and can be seen only by 3-dimensional ultrasound a few months after delivery. We do not have data on that, but on the immediate intrapartum diagnosis of lacerations, we did not find a correlation.
I have a question for Boris from one of the audience. Are there any studies on African pelvises? Are all of these dimensions and all of these studies in white women?
Yeah, I saw this question in the questions and answers, and I said that it's fascinating, and I'm not aware of any of these. The colleague said that there's differences in the pelvic dimensions and the correlation of the engagement in primigravid women that differs between African women and non-African women. So it's definitely an area worth studying. I have no data on it.
And then I wonder whether Professor Gebo wants to make any comments. He's one of the pioneers in this area. Is he around still?
Yes, I could say that about the African women. Can you hear me?
Yes.
About the African women, there is really a colleague working in Accra, Ghana now. He's so interested. He's called Dr. Yor, Y for Yor, and he is really studying the African women in West Africa now. I think there might be some difference in the pelvic shape in these women, so it will be very interesting to study these African women also.
Yeah. On the issue of, for Russia, really, we played with this type of models 10, 15 years ago. You get various associations between measurements and outcome of induction of labor. But at the end of the day, what does it matter? The rock curves are quite shallow, actually. So you're not going to have a prediction model and then suggest that these women should have a cesarean section, because you will end up doing a hell of a lot of cesarean sections unnecessarily. So I'm not quite sure whether we can easily translate the nice associations with outcome of labor and induction of labor with something practical.
Well, it's very stressful to the woman and to the obstetrician when they undergo the process of induction of labor and then it fails. So I believe that a woman should at least be counseled for the probability of the success of such an intervention, and she can, with her doctor, make a choice. Especially with nowadays that
what would the choice be? Sorry, what would the choice be?
She will, but it's up to her. But she has to know if there's a high probability of cesarean section here. If we go to induction of labor, whether she would want to wait till she enters into spontaneous labor, whether she wants to go for elective cesarean section to begin with. Now there's the advocacy. It's very much in fashion, the induction of labor. 38 weeks, 39 weeks to decrease the incidence of stillbirth. There are certain medical disorders that would justify induction of labor. So in these cases, I think it would be very beneficial for the woman to know her chances, and then she might consider it, and she might, what we call informed choice, she might make a choice according to this kind of information that we give her.
Rock curves of areas under the curve of 0.7, 0.8.
0.88.
Really, yeah. Honestly, you will end up terrorizing women, I think. You give them a high probability. You will increase the cesarean section rate unnecessarily, I am afraid.
I don't really see it that way. I mean, as a woman, I would like to know if I'm going to consider induction of labor. I would like to know what my chances are, and then it's really up to me to take the chance or not.
If you're in Cyprus, you don't need to have this done because they will all have a cesarean section anyway, especially
in Egypt as well.
Right. So, and in England, there is a massive effort to reduce the cesarean section rate. Lisa, another good obstetrician. You used to call some of these things toys for the boys.
Another real obstetrician from the past. Yes, the question of Boris was a very good one. Does this improve outcome? And that holds for all modern technology, and especially also for ultrasound during labor. And I agree with Kipros. It's rather doubtful if it will help. If you have, like in Egypt, a very high cesarean section rate, if you have a prediction model, you will only increase it further, most likely, unless you only give information to women and to tell them, oh, we made a calculation and you have a very low risk for a cesarean section. Then you force, probably, the obstetricians much more to wait a little bit longer. So use the low risk instead of the high risk cases. I remember quite a few decades ago when I did my PhD on induction of labor, our cesarean section rate for induction of labor was 5%. So you can't get it much lower. So that in those cases, you don't need it, unless you don't want to have the prolonged labor that we had in the past. So please try and show that it works. And what are the endpoints? Do you want to have a reduction in cesarean section? Do you want to have a better long-term maternal outcome for the pelvic floor? Do you want to have a lower incidence of cerebral palsy? Even to define the endpoints might be quite difficult.
Well, I was just going to say, why are we assuming that the probability is going to be high? I mean, there would be some calculations where the probability of the cesarean section would be low, and then we would actually be, encouraging the process of induction of labor. Besides, induction of labor is really exhausting for the economically wise for the healthcare facilities and everything. So we are trying, as one of the endpoints, is to reduce the exhaustion of the resources.
By doing a cesarean.
By not doing an unnecessary induction of labor and keeping the woman for a day or more or longer in the hospital when we would actually know that she will end up in a cesarean section. And this is extremely stressful. Extremely stressful for the woman and for the doctor as well.
Yeah, I know everybody is very stressed in labor. But if we get the low score and then what? We induce them in a day or two, that would dramatically improve the outcome? Is there any good evidence for that?
No, if we tell her that you have a 10% chance of delivering normally, then it's really up to her. Then if she stays for 2 days trying to be delivered vaginally, and in the end she delivers by cesarean section, she's not going to jump at your throat and say, why did you keep me all this time? And as well, I think there's some auditing measures in the hospital as well, where they would see, why are we carrying out unnecessary interventions, one of which is the induction of labor.
The point is coming from the school of thought of the combined test and screening for Down syndrome, where you have a 5% false positive rate and a 90% detection rate, or very, very high performance of screening for preeclampsia, for example. When I look at those curves, they are quite pathetic. They may be significant, but they are quite pathetic. To get to the 70 or 80 or 90%, we will forcibly classify 20 or 30 or 40 or 50% of the population. Look at your curves. I don't know actually if you have it there. Do you have your presentation? I'm sorry for. I want the statistician. I want either David Wright or click the other one as well, so that you have both of them. David Wright or Howard Cackwell, to tell me how good this would be if we had a method like this in screening for Down syndrome. I can see a false positive rate on the right of 25% for the detection rate of about 60%. Howard, I can hear you now.
Yeah, it's these are obviously, you're right, these are very flat and very weak curves. They don't go up into a corner of the picture, they just parallel the line of no effect, the 50% line. And yeah, they are weak. If that depends what you want to do with it in this critical situation.
To decide whether to do a cesarean section rather than use labor.
This seems a rather weak. You need something much more diagnostic. In other words, the rock curve is sitting pushed up into the top left-hand corner to some degree. I mean, it looks like it is on the right-hand one, the validation one, but that's noise. There's a lot of noise there. There's very few cases there. So the left one is the one that's probably the best you can get for this marker. And Kipro says it's not very good to act on.
That is the problem. I don't know what Boris or EGEPO. I mean, these are people that have spent a lot of time on this. What is the next step to convince anybody that you can actually act on this? And what sort of studies do you feel you need to have?
Fabian?
Yes. You want me to comment? Yes, I think we should focus more on maternal satisfaction, because the women prefer to have an ultrasound instead of a vaginal examination, and we should see how satisfied they are also after an intestinal labor. And I think it's very difficult, probably impossible, to have a very good ROC curve in this situation. The labor is a complex situation with a lot of factors influencing the outcome. So I don't think we will have this 19% detection rate with 5% false positive rate. I don't think it's possible for the labor. So yes, I can in one way agree with you, Kypros. Perhaps women should try induction of labor when there is an indication, and then we should follow the labor progress, but stop when we have a situation where the labor stops, when the progress is slow. I think I agree. It's very difficult to pick up the cases before start of labor and say you should not try.
A very important point really is this battle, the war to the end between midwives and obstetricians. And you'll have countries where the delivery doctor, the ones that undertake deliveries are doctors, in Greece, for example. And you have countries like yours and England and the Netherlands and so on, where there is a very important role, by far the most important role, for midwives to play. And if we have technology that belongs to the doctors, it will almost become something that is completely rejected by midwives. And I have Mark Gill, they are from Madrid, that has carried out a nice study to see whether midwives can be trained to do these measurements. Mark?
Thank you, Prof. Yes, we did a study basically that showed that midwives perform the same, the accuracy of their measurements were as good as those performed by doctors. So we carried out more than 100 measurements and the correlation was perfect. So we concluded that it was a technology that could be easily applied by midwives.
And from what you are telling me, Mark, the midwives in your hospital were very enthusiastic in adopting this technology.
They are, and actually they are now doing their own studies. They are teaching women to push while they are in the second phase of labor with the scan. And they're also trying these positions that they like so much, correlating the evolution with ultrasound. Yeah. And they decided to do that.
Thank you, Mark. I also have a fetal surgeon around. People know him as a brilliant fetal surgeon, but actually he thinks that he's a better urogynecologist. Jan de Prest, you wanted to make some comments? You're doing some studies yourself on...
Yes, thank you, Prof. Thank you, Kypros. I was interested indeed in how predictive all these measurements could be into pelvic floor trauma. I can understand instrumental delivery, cesarean section is one thing, but what a woman certainly worries about is making her choice for vaginal delivery and avoid pelvic floor trauma. Is there any reason, Ali or others, to think that this would be predictive of pelvic floor trauma?
Good question, Jan. I think we have talked about, and I still don't have a clear answer. But well, from a data point of view, we do not have data, but I would be really curious about the association of levator ani coactivation with levator ani muscle avulsion. Okay? Because normally the levator ani muscle should be stretched too much during labor, and what happens is that in 15 to 20% of women, the muscle gets detached from its insertion due to overstretching. So having a muscle which is not able to relax appropriately, it may be a risk factor for having a high risk of detachment. this is an idea. It's not an affirmation. So,
but Ali, we must think critical. We can do very nice studies. It will provide us a number of papers, but at the end of the day, the predictive value of these things have to that it really solves a clinical problem. I understand. I mean, 20% has elevator avulsion, but so many will never develop problems of it. So when we start to use it as a management tool, so again, what is the philosophy?
Well, I think maybe if, from my presentation, the message was not very clear, or maybe some message was confused. I do not think that the pelvic floor, that we will have enough data to guide us to decide on the mode of delivery depending on the pelvic floor information. I think that we can use the antepartum pelvic floor information to help women improve their outcome during delivery. Okay, so it is not a case against vaginal delivery. Okay, it's a case for a better management of vaginal delivery.
There's another question that keeps coming up. We have ignored the baby completely in these studies, isn't it? Is there a role of predicting or assessing the fetal size in predicting outcome? We have focused now too much on the pelvic dimensions. And Gebon, you come in a country with very big babies. Do they matter?
Yes, I'm not calculating the size of the baby, but we have a new idea now. I'm working together with Rasha and a colleague called Iversen in Oslo, and we are focusing more on the fetal head above the symphysis than instead of below the symphysis, because at the moment usually angular progression is measured. But our group has now suggested to measure the angle above the symphysis, a line through the symphysis and the tangent to the head above. And Russia published and presented in the Island meeting 1 month ago a very good correlation between the angle above and the angle below the symphysis. And it would be much simpler for obstetricians to do this. So there seems to be a barrier for obstetricians to put the transducer to the perineum. So if it's possible to measure fetal station from a transabdominal scan, it will be very beneficial. So that's what we're trying to do at the moment.